Hello, a very good afternoon, very good morning, very good evening, depending on what time of day that you're watching or listening to this. I'm Ian Dale. I'm going to be chairing this Levelling Up seminar. It's the latest in our series of seminars on levelling up. I think it's probably around number 15 now. And we're going to talk about levelling up in the field of health and healthcare today. And if you think about it, there couldn't be a more important subject than this, because if people don't have an equal start in life in terms of how they're brought into this world, how they receive healthcare over the course of their life, it's very difficult to see how the levelling up agenda can ever be completed. Well, let me introduce our panel to you. No Justine Greening today, but for one day only, Anne Milton is going to be Justine Greening. It's a bit like stars in their eyes, this, isn't it? Anne Milton, as many of you will know, was Minister for Public Health in the coalition government, and she also trained as a nurse at St Bart's Hospital in London. And of course, we also have a guest from St Bart's Hospital. His name is Andrew Atfield. He's Associate Director for Public Health at Barts Health NHS Trust. Now, Andrew, you've really got to impress me today, because your new chair, Jackie Smith, is one of my best friends. So I could put in a good word for you if you perform well, which I'm sure you will. Also with us is Emma Latimer, Accountable Officer of Hull Clinical Commissioning Group and Geographic Partnership Director for Humber Coast and Vale Health and Care Partnership Integrated Care System. That is the longest job title I've ever had to give on this series of seminars. And Nick Hume is Chief Executive of East Suffolk and North Essex NHS Foundation Trust, an area very dear to me as I grew up there. So welcome all. I'm going to hand over now to Anne Milton to give a little introduction to the kind of areas that we're going to cover today in this seminar. Anne.
Thank you very much, Ian, and it's a pleasure to see you all. We met Andrew and Nick on a call already. I don't think we've met Emma, but this is a subject close to my heart. It's in many ways what drove me into politics. Few nurses end up as MPs, and it was the inequalities I saw in Hackney, which was the most deprived borough in the country at the time I worked there, that drove me into politics to see if I could make a difference that way. It's not just the inequalities in health that I saw, it was the inequalities in housing, in educational opportunities and in employment. All those together, of course, have an impact on people's health. And I think the really striking thing for me is that nobody is outraged by the discrepancies in both life expectancy and healthy life years that we see. So even in relatively affluent areas, you can drive 5 miles and see a drop of 8 to 10 years in life expectancy. In some parts of the country, if you look at healthy life years, that discrepancy is 25 years or more. So really shocking figures. Neither government or the public are outraged enough by them, because if we were, we would have done something about it, you could argue. However, it is the case that irrespective of the political persuasion of the government at the day and the desire actually to do something about it, nothing really shifts. I was Public Health Minister when Michael Marmot published his first report, and he published his second report 9 years on in 2019. And actually what it showed was that inequalities, if you look at the life expectancy of men in the most deprived parts of the most deprived wards in the northeast, their life expectancy had actually gone down since 2010. So we have a big problem. The question is how we find solutions. We think that levelling up, these levelling up goals, are one way that we could achieve it. As former Skills and Apprenticeship Minister, I am firmly of the belief that if we want to do this and change things quickly, actually education, those early years, making sure young people have an opportunity, making sure they have positive post-16 destinations, is the one way that we can impact things, probably head and shoulders above any other interventions. Improving public health is more than just about stopping people smoking, reducing obesity, as you all know. What we've got to do is to achieve social and economic change and improve the life chances, not just of young people, but of older adults as well. And that is probably enough from me, Ian, to kick us off on a discussion. But I'm happy to come in at any time you feel is appropriate.
It's never enough time for you, Anne. You
Thank
know
you.
that. All right, let's go to the rest of the panel. I want to just kick this off by asking you, what does levelling up health mean to each of you? And can it truly be achieved? I hope you're going to say yes to the last bit, otherwise there's not much point in our discussion. But Emma, let's start off with you. What does levelling up health mean to you?
I think levelling up health means everyone has the same opportunity. I think talent is evenly distributed, but opportunity isn't. And so I think, as you say, it's not just about access to healthcare, it's the wider determinants. And so I think the newly formed integrated care systems that we are planning to move into gives us much more opportunity, because we need to work across the wider determinants of health around housing, education, skills and employment, as Anna's already alluded to, in a much more connected way. To ensure that people are not left behind. So I absolutely believe we can do it, but it's a long-term strategy. It will take lots of effort, and it will take long-term planning across all agencies, not just individual organisations or individual public sector agencies looking at it in isolation.
Do you think that, I mean, Anne talked a lot about life expectancy there, which is one measure that where you can, I suppose, measure whether there is whether the whole country is equal. But we have a national health service, and yet, depending on what particular part of the NHS you want to access, it's not national, is it? The level of service that you get in one part of the country might be very different to another, particularly in things like cancer care. Is that something that we ought to be talking about in terms of levelling up health as well?
Absolutely. In terms of access to specialist care, the problem is that we have shortages of workforce in parts of the country, which mean that people have to travel further, and that again leads to disadvantage. So I think, again, with the, I don't want to harp too much on about it, but the integrated care system really starts to look at population health management and data in a different way. So, I mean, I've been in the NHS for 32 years, and I feel as though a lot of our time has been spent on looking at big contracts, giving lots of money through contracts, and not actually measuring the impact of the money that we've spent in health. What has that meant actually to people's own health and well-being? So I think there are huge opportunities to do things differently. But actually, if you looked at one part of the country that I serve, which is East Riding, there are 7 sort of neighbourhoods within that. One is Beverley, and the other is Bridlington. And again, you're looking at 5-10 years life expectancy difference in those patches. So actually, you know, one size does not fit all. So whilst we are a national health service, we have to recognise that blanket commissioning doesn't work either. And we have to understand our communities, understand what matters to them, and get close to them to start to work with them to try and change the opportunities that are afforded to them.
So Nick, let's come to you. What does levelling up on health mean to you?
So for me, I have the privilege of working in a part of the country where we have the healthiest and wealthiest electoral ward in the country in Aldeburgh, and the most deprived electoral ward in the country in Jaywick, separated by 40 miles of coast. And where do the movers and the shakers live? Where do the politicians live? Where's the investment? Of course, it's in Aldeburgh. So I think we can't pretend that tackling some of these issues isn't going to require 2 things. First of all, a huge amount of courage from both local and national politicians, but also a long-term plan, so that the investment isn't made on a political cycle of, unless we get a return within 3 years, then we're not going to invest in. It's very easy to get investment in the elective recovery programme, because votes will come with that. So I think we can't ignore the political aspects of this. I think absolutely would agree with Emma that I really welcome the local approach through the ICSs and through application at place in terms of investment. Less top-down funding and decisions made centrally allows us to hold each other to account in the ICSs to make sure that the investment is going to those areas where it's most needed. We're measuring the wrong things. We shouldn't be measuring how long people are spending in A&E or how long on a waiting list. We should be looking at the differential waits that people have in those various communities. I think finally we need to be looking at some of the diseases. We know that heart disease, for example, which in the main, and this is a great generalisation, I'm sure that some of my clinical colleagues may have a view, in the main affects people like me, white middle class people who perhaps are a little bit overweight, can kind of sort themselves out. Look at COPD. We've seen no improvement in terms of deaths with COPD because it tends to affect a lower socioeconomic, therefore less influence, therefore less ability to influence the political agenda and the health agenda. So looking at specific diseases, not just cancer, which is the natural one, but other diseases as well, which are diseases of people who live very difficult, challenged lives.
Let me be controversial for a second, Nick, and say you've criticised politicians there a lot, but you're the one that is surely capable of doing something about this. You are chief executive of an NHS Foundation Trust. Surely it's up to you to decide. Presumably you've got a board as well that you'd have to convince. Presumably it's up to you to decide which parts of your area these resources go to.
So far be it for me to criticise a politician. I've got a mortgage to pay, but yeah, you're absolutely right. But I'm held to account for delivery against a set of objectives that are set by the Department of Health, and going rogue on those. And we do try. And I think again, to Emma's point earlier, if we are going to talk at system by default, if we are going to give that degree of authority and autonomy to systems rather than be centrally controlled by Department of Health, then I think we need to be honest with that. So absolutely, we do make every effort to change things. We do make every effort to invest more in, frankly, in North East Essex rather than in Suffolk, because it's a great generalisation, and I accept that Suffolk is healthy and wealthy, but by comparison it is. And therefore we do put more staff. But you can imagine the outcry from the people of Suffolk who are saying, well, we deserve the same. We can't make the offer universal if the needs are not, and the needs are hugely disparate. And therefore we need to listen to the needs and not just the universal offer of pretending healthcare should be offered at the same rate, at the same level to everyone.
Before I come to Andrew, let me just go back to Anne a second on that, because you've been at the sharp end as a minister of the Department of Health. How much do ministers set the parameters that Nick has to operate under? How much is it done by the Department of Health or NHS England?
Well, it would have changed since my time, and I was public health minister.
It wasn't that long ago.
Well, it was undoubtedly would have changed. I left just as the Health and Social Care Act of 2012 went through. But Nick's point is well made, that actually those targets, whatever those targets are what drives the management of any trust. There's no doubt about it. 4-hour A&E waiting times is the obvious one. But when the tabloid headlines are all about A&E, then A&E is what everybody concentrates on. And although the Conservative government, the coalition government, got rid of a lot of regional bodies, actually there is a lot of shouting and screaming at managers from the top if those targets are breached. So without a doubt, and Nick's point about chronic obstructive respiratory diseases is very, very well made. There is some latitude for NHS trusts, but if you've got somebody screaming at you from the Department of Health, that's what managers respond to, not surprisingly.
And Nick, how often do you get screamed at from the Department of Health?
To be honest, less so. I mean, I think there has been a shift now away from, we have to remember what's happened in the last 18 months. And clearly a lot of the targets that we originally thought about have kind of faded a little bit. But also we can't ignore the last 18 months. What we've seen with COVID is it's not only exposed but amplified those inequalities. Look at the mortality rate in tendering, which is where JWIC sits, is the highest in the country per 100,000. And that's because that's where the poverty is. So we have an opportunity to take the learning from COVID to make sure that we don't slip back. So there's less shouting, or maybe I've just become a bit old and cynical, but or maybe I'm just ignoring the shouting in that I'm staging my career. I don't need to worry too much about it.
Andrew, profuse apologies for taking so long to come to you. What does the levelling up agenda in health mean to you?
Thank you, Ian. I just want, listening carefully to all the colleagues on the panel there. I mean, I was looking at some research yesterday from the LGA, I think, which shows twice a mortality rate twice as high in the most deprived area to the least deprived area. So to use the Essex-Suffolk example from JWIC, I mean, that's quite a concrete example, really, and that's how serious this issue is. I think from our point of view, we're a big hospital group. Bath is one of our 5 hospitals. Royal London in Whitechapel, another one, and part of the East End. And over 10 years, really, we've been working on programs to support the health and well-being of East Londoners, which in our view helps to address the inequalities in those populations. If you know the patch, you'll know that it has most richest areas, some of the most richest areas in Britain, in Canary Wharf and City of London, and some of the sadly still some of the most poorest areas. So this has been on our mind for a long time, and we've taken it seriously there. I wanted to direct, there's three things we do really. One is we look at we measure the equity of our care. We've done a big program of work on this. There's a lot more to do on it. We're measuring it by social background, by ethnicity, by particularly disadvantaged groups such as people with disabilities, learning disabilities, and so on. We look at the way we implement care to see if it can be done better in terms of preventing ill health. So work around cardiac and diabetes cardiac health and diabetes are two themes that's particularly strong. And the area I've been particularly my background actually is kind of economic development and employment before I went to public health, is looking at the wider determinants of health. I won't have to tell Anne this, but under any calculation, the biggest single set of reasons why people are ill or healthy is because of the social economic background. Most people attribute it to more than 50% of the causes, so there's different ways of calculating it. Emma's made a similar point earlier on, I think. So we do that, and I think there's something, I don't know if you've read the King's Fund report on NHS and poverty, which came out about February this year. I was refreshing my mind on this, and one thing I think it says right early on is the NHS is not without power in this. So this is about us using our power as an employer, as a procurer of goods and services, and looking at the environment we use, how we work with the community, and how we encourage enterprise. So that's the sorts of things we've done. So over the last 10 years, this does relate to levelling up quite seriously. I think we've got about 1,500 local East Enders into jobs within the health service. Every year we engage with about 1,000 young people talking about health careers. We get health doctors, nurses, midwives talking to schools that otherwise may not ever see a healthcare professional, other than maybe the school nurse, hopefully. We just started doing a bit of work around social value and some of the work that actually local government's been doing for ages. So what it means to me, well, somebody continuing what we're doing. I think that the data around COVID is quite like an X-ray of inequalities. It hasn't gone away. Obviously, we're talking about social economic aspects, but there's a strong cross-reference to ethnicity as well. Everyone knows, would have heard of the disparities in the outcome report that Public Health England has done. And in urban areas like London, in our parts of London, obviously ethnicity, deprivation go hand in hand. They're not the same thing, but they do go hand in hand. Can we make a difference to it? Well, it has got worse, so I think it can get better. Is the simple answer on that, and we have to look at that. It's not an easy task, and again, I'm listening to what Nick was saying. Really, is that this is quite ingrained. Really, it's not just the NHS's role either. It's something we can't do on our own, but we do have some powers, and we should utilise those powers as far as possible.
Well, let's extend that discussion a little bit with Emma. I mean, how do we level up inequalities in diverse communities throughout the country? I mean, you're in a very different part of the country to Nick and Andrew. What are the challenges that you face?
I mean, obviously, we have some significant deprivation. Hull is probably one of the most deprived cities in the country. And I think the problem is when you start looking at, to look at equity on waiting lists, I go way back to people who don't even get near waiting lists. That is the issue that we've got. We're talking huge amounts of deprivation, wall-to-wall deprivation, people who haven't accessed employment for years, generations who haven't accessed employment for years. So, even to get on a waiting list, for some of my population is a massive step too far. So it comes back to, we're doing things like looking at being a trauma-informed city. I know Plymouth have done that. So actually starting to understand the reasons people, actually what's happening in somebody's life rather than what we're trying to do to people. I think, we still take quite a medical approach to the way we work. We're looking at having long-term relationships with schools and working with our UTCs, our technical colleges, around looking at health and care apprenticeships, the swaps scheme that the government are doing with the jobs, the DWP. We're looking at industrialising that, and actually we know we've got huge. I think there's been 36,000 jobs lost in the Humber since the pandemic. A lot of them have come from hospitality and travel, etc. So again, we're looking to try and capture that, because there's a huge supply and demand issue, and we know that getting people into work is probably the best thing we can do to improve their health. So I think this is, this goes way beyond access to healthcare. This is deep-rooted cultural issues that we need to get close. And we've done loads of work with our communities. We had a Healthier Whole Community Fund, which was participatory budgeting. So we were getting communities to vote for very small amounts of money that had absolutely massive reach into communities, things that us in our big statutory organisations would never have dreamt of. The creative, innovative sort of schemes that came up from planting lavender with school children down one of the most, I suppose, the drug sort of barren streets in Hull, compared to, mending bicycles to give to children who couldn't afford them, to getting people into jobs and employment. We've got to be creative, we've got to think differently, but we've also got to have sustainable things. Pilots, to me, when somebody says to me, I want to do a pilot, it does worry me. These things we've got to own them. They've got to be big enough, bold enough to make the difference. And also, we're never going to have the evidence to know whether these things are going to work or not. But you know what? We can't, because the evidence will end up in 3 or 5, 10 years time. And I think, as healthcare leaders and system leaders, we've got to get a lot braver at saying, do you know what? Have a go. Not, I want to see your KPIs for the next 20 years, because that just turns the people off. So I think it's about having a really joined up approach across all sectors, particularly working with our local authority, the voluntary sector, but the communities themselves, who often hold lots of the answers and solutions. And so, I could talk for hours about some of the stuff we've done in Hull, which I think is truly remarkable. We were partners in the City of Culture. When we became City of Culture, we were a major sponsor. And I got a lot of criticism from people saying, why is health? You should be spending that money on waiting lists. And, but actually, I think I spent the equivalent of 10 heart operations, CHD operations, but actually that reach again to that community, what it did to people, how people felt about the city they lived in, you couldn't put a price on that. So I suppose, I know I'm sort of, I'm so passionate about it, because I think, we can do so much, but we have to start, not looking at what's turning up at the healthcare, but actually why aren't people turning up? What are the issues? And how do we support and help people to have those opportunities that the people that Nick described have, and they have in Beverley, where, in a place near where I live, because, we're from, and they're only 6 miles apart. It's unbelievable. So I think the ICS, and again, I keep coming back to the ICS, but the ICS is so important because it looks way beyond health. And that's the only way we're ever going to improve the health and well-being, I think, and level up of the citizens and the populations that we serve.
Emma, that's really interesting. And let me come to you on this, because effectively, I think what Emma was pointed to was that maybe there's not enough people in politics, in the health sector, in maybe among health service professionals who are willing to take risks, that people are too risk averse. Do we need a few more Louise Caseys in the health area, do you think? People who will bang a few heads together, take some risks, and yeah, some things may not work, but other things may work a lot better than you may have imagined.
I think your point's well made, Ian, and Emma's story is very compelling, how small amounts of money can have a profound impact. And I did quite a lot of work in Hull when I was Skills and Apprenticeship Minister, because college needed quite a lot of support. But your point about politicians being risk averse is spot on. I don't like pilots. I never liked them. When the Department for Education was running a pilot, I said, no, don't let's run a pilot, let's do it and evolve it. You can make changes as it goes along, but they're very expensive, because certainly if they're government run, the evaluation itself usually costs several £100,000, to be honest. You've got to try things out. If they don't work, you can ditch them, or you can make changes at the edges, because the urgency of all this, Ian, can't be underestimated. We had big inequalities before COVID. COVID has probably made those wider, The real danger is that those inequalities become entrenched. And I think, Emma's point again about the pride people have in the place where they live. A lot of people don't get on the waiting list. They don't come forward because actually they don't expect anything more than what they've got. And that is what means that their elbows aren't as sharp as others. And that is one of the big problems that we're facing.
Andrew, do you have anything to add on maybe people being too, or not being too risk averse in the health service?
Yeah. Well, I think, the way we run health is constantly run on risk, and for very good reason. The last thing we want to do is put patients at risk. But I think I do think it'd be useful to move out the language of risk assessment towards opportunities. And I think what Emma's been describing in Hull, and I've read a little bit more about that before this seminar, but is fantastic. It's the community engagement bit is actually really interesting, and I think there is a risk there because we, certainly from the hospital sector, we tend to engage with the community in the form of a defensive complaints type of mentality, and that's actually the worst thing we can do. During COVID, we set up an interfaith forum. Everyone does this, but we haven't been doing it. So we had rabbis, imams, and people from various Christian congregations and other ethnic groups. Obviously, we're a very diverse community, and they were so pleased. Actually, someone actually come from the hospital to talk to them. It was almost embarrassing, really, because we thought, well, we should have been doing this for years. So that's the kind of thing. It's not so much about being risk assessment, but actually being a bit more outward facing and not being afraid to take criticism. People are critical, it's hard work running a hospital or whatever. You get, if you get it wrong, it's life threatening to the patient and the family. And even if you get it right, you sometimes criticize. So I think that kind of difference of approach is really important. So to start to think about opportunities, start about building partnerships and building wealth, that's the sort of language they use in local government, is actually quite good. You have to do it carefully in terms of expectations and so on. But that's the sort of language I think we don't hear very much from the health sector.
In terms of, you touched on community engagement there, and I think this fits into a lot of what Emma was saying, reaching communities who maybe haven't traditionally engaged with the health service in the way that you might want them to. Nick, you mentioned Jaywick earlier on, which is in your area, one of the most deprived parts of the country. How much does your NHS Trust try to enhance community engagement to get people to really interact with the health service in maybe a way they haven't done before?
Really good question. So when I'd been a coach for about a year, I went out to Jaywick and met, just because it was a complaint meeting actually, and I went to meet the family in their home rather than ask them to come in. And I sat down and the woman said, "Oh, I suppose you're going to ask us what healthcare we need." I said, "Yeah, we're really interested." She said, "I'm bloody fed up of telling you. I don't want another group of people coming in and saying, what is it that you need from us in health? And then you all go away, so I'm not going to tell you." But what was interesting was that actually, I've actually got to know quite well, it's a kind of touch point of a lot of the work that I've done. I know it's only one family, is that we've got to know each other quite well over the past few years. And I thought that what she'd want to talk to me about was health. So in the end, she said to me, she's very forthright. She said, "I suppose soon you're going to ask me about my mammograms and my smears, are you?" And I thought, well, actually, it wasn't top of my list to talk to you about. But she said, "So Nick, let me tell you this. I haven't thought about my own health for 20 years because I'm worried about paying my rent, because I'm worried about my kids at school. I'm worried about my husband coming home and beating me up. How much time do I get to think about? And even if I did, I haven't got a car." So actually, although we've got some of these really grand ideas around what we think people need, and we engage and we talk about different access and what have you, actually it's often something really, really simple. We can't listen enough, but we have to then do something. I do not want to say, and I've said to the new ICS leadership model, the new leadership team here, I don't want to see one more report telling me how awful the lives are of the people in tendering. We know it, we've known it for 30 years, and they're getting worse. When are we just going to do something? So I think we've talked about risk and everything else. About the word we haven't used perhaps is courage. So if I just give you one example, we're looking at waiting lists at the moment, which I'm sure everybody's looking at waiting lists. And we've agreed, not easily though, I have to say, with some of our clinical teams, that we're going to prioritise people with learning disabilities, because we know that the outcomes of people with learning disabilities are worse. There's international evidence to prove it. So we will put them to the top of the list. Now, even that relatively small decision has caused some pushback. And I'm now talking about, so if we have,
Who
as
from?
Sorry?
Who from?
From our clinicians, some of them. Why should they get priority? And I said, because they have the greatest need. I've had a letter recently from a postman who's waiting for a knee operation. He goes on to 0 pay in 3 months' time. He's on half pay at the moment. So he's been waiting for 8 months. His wife doesn't work. She has a manageable but quite severe mental health condition, but not so severe that she benefits from benefits. And equally, we've got waiting lists of people who are retired who'd quite like a new knee because it would improve their golf swing. Now, I'm exaggerating for the point of making a point. Should we see people in turn, or should we see people where the impact of that operation will have a greater improvement generally on their lives? That is a huge decision that we need to make as the NHS. I'm very clear what we should do. We should do proper assessments on the impact on somebody's life of them having a waiting list. And when you're looking, sadly, at waiting lists that some of us can remember from the 1990s, prior to 97, then those are some of the conversations with that bravery, the risk assessment and everything else that we need to have. We can't just continue to see people in turn, for example. We can't ignore the fact that we can provide the best possible healthcare in settings that people simply can't get to because they haven't got the money to get there, or there are communications.
And that decision as to what to prioritise, should that be taken locally, or do you think there should be national guidelines from the central NHS? And if the latter, who should be making those decisions?
It should be the local decision. Rip up the national guidelines. They're not bloody relevant. They're written in London for people in London, most of them. Now, I spent 30 years in London defending London. I've been out here for 10 years. Now I defend the counties to my dying breath. Yeah, I think there should be very, very high level guidance. Well, actually, no, I'm going to change around. We need permission from the centre. We don't need guidance. We need permission to do what's right for local people. We need to talk to local people and listen to local people, but also hear the voices that are seldom heard. Because I know that if I hold a patient meeting, everybody who turns up will be articulate. Most of them will be white and they'll all be mainly middle class. They are not the people who need help in terms of accessing healthcare.
That's quite a difficult message to sell to a politician, though, isn't it, Anne? Because politicians inevitably gravitate towards the people that actually bother to vote. And we all know in some of the communities that Nick's talking about, they don't. And if you live in if you represent a marginal seat, how can you possibly meet the demands of everybody?
Well, you can't. And I mean, Nick touches on this rub that has always been there. I cast anybody who's old enough mind back to Jennifer's ear. Ian, you will remember the story.
I do.
Right. So local decision making is thought
Emma's
to be
too young.
Emma's too young. Local decision making is a good thing until it becomes a postcode lottery.
Yeah.
And then it's a bad thing. And that is the problem. So one of the ideas behind the Health and Social Care Act 2012 was to lift it away from the Department of Health that NHS England was set up. But I think that you've got to have people who are brave enough, like Nick is being, to take on some of the clinicians and the decision making that they adopt in deciding who gets what joint replacements first. And I think you've got to try some of these things, to be absolutely honest. So I personally am a great lover in devolution. I think local people make good decisions for their local areas, to be absolutely honest, because they know their communities. I think what's hampered them is the barriers and obstacles in their way. But as I say, although politicians will say they love local decision making, They're absolutely fine with it until you creep up to an election, as you rightly point out, Ian. And then it all comes a bit more tricky. But it is one of the reasons, I think, that lies behind the general inequalities in health. The timelines are very long. They're well beyond the life cycle of a government. And that is a problem. If you open a new hospital in the next 2 years, you've got a nice photo opportunity, it's a built structure. Politicians love those sort of things. Doing the sort of community initiatives, maybe online initiatives, you've got nothing to open and no building to open. So I'm not being critical of politicians, because that's the way of the political world, but I'm saying it doesn't necessarily go with the grain of improving the public's health.
I think it's really interesting what Nick and Emma have said there, in that how do you engage with communities without doing the normal sort of consultation, sort of, well, what do you want us to do? And then people getting so hacked off when nothing actually happens. Is the key to this, Andrew, engaging with different partners? I mean, how important are local partnerships in addressing health inequalities, and can they effectively be the agents for change?
Yeah, I think so. I think we have to be kind of humble in health, really. We are in charge of a massive health budget, a massive health system, and things like that. But basically, it's often, you know, I've cut before. One meeting I had before today was with colleagues in London Borough and Newham. Newham's 350,000 people. It's not a small place, you know, some of the things they're doing around, and you know, thinking about poverty and you know, thinking about poverty proofing some of the education pathways and things. This is some of the jargon, really. I'm not quite sure what it means, but I like the sound of it. It does, you know, I do feel quite humbled by this work, but that, because they're often on the sharp end of things, you know, particularly in the hospital sector. We see them, we get them through the door. Hopefully we send them home as quick as they're healthy enough to leave, and so on. And you know, as far as that's possible. But it's, so I think it's about kind of thinking about this as sort of multiplier and partnership effect. Is that we can't do this on our own. We significantly often feel like a bit of an absence in some of these partnerships. So it's good that we're there. I think the universities and education institutions have a huge role to play around this as well. So if you put universities, local authorities, and the health system together in one room, actually saying we want to make a difference to the community inequalities, you've got some very big players. And that's the whole point of this kind of anchor institutions type of approach. You know, it came from, you know, it's a bit of American jargon, really, but I think it's got a lot of promise, because it's actually you know, it's thinking about some joint work. And one thing that we're focused on, particularly young people, with young population in our particular patch. Child poverty is an enormous problem. In Bethnal Green, Bow, where Whitechapel's, you know, where our main hospital is, about 60% of children are in the traditional definition of poverty. You can't. These are things that you know, you can't do on your own. I suppose the last point I would make on this, and I'm actually very excited about ICSs. It's an appalling bit of jargon, of course, but I think actually there is a lot of potential in ICSs, because it's got the
So
local
just
authorities
explain
in
what
there.
an ICS is.
It's an integrated care system. Nick will know more than me. Indeed.
Sounds
Emma
very
as well.
exciting.
It doesn't sound very exciting, but basically it's about putting local, you know, putting care and health together potentially. Also, I think, as I said, there's a real opportunity to bring the education sector in there. And also, you know, this is where where government could do a lot of difference. At the moment, we're funded by the job, as it were, you know, by the tariff system in the NHS. If we are going to make a real difference in public health terms, then we should be setting targets around the general health of the population. You know, 10 years is probably the minimum kind of cycle to work on, and actually say, look, you know, you will be held to account on that. And also, frankly, is that you're given the money to do it. You know, there's no, you know, if a deprived area has been under the hammer, as they have been over the last 10 years, then they're not going to have the resource to do that. And in fact, it would become even more divisive. Discussion that we had around learning disabilities, for example, would become incredibly divisive. You know, it shouldn't be that. It should be about expanding the expanding the cake so that we can have a more generous portion to a multiplicity of deprived groups, rather than have a rather grim fight between different priorities.
Emma, looking at the work that you do, give us some examples of where you partner up with local organisations, whether in the public sector or indeed the private sector, to enhance the prospect for poor communities to actually access healthcare.
Well, one of the things we do with the local authority, we have a carers lead programme. So basically, anyone in care, that we partner them up again with in the local authority, but also with local businesses, again trying to get them preferential access to employment and housing, etc., because we know they're the most disadvantaged. Some of the most disadvantaged children and young people in our society. So we do a lot around that. We do a lot with the university. We did a big piece of work. I led a piece of work about trying to create more opportunities for young women. And because a lot, again, in cities like Hull, you've got lots of young girls who are told that they've got to go to work, they've just got to get a job, they can't access education, they need to bring money in, and therefore they don't get the access to education that perhaps other people do. So again, we've been doing some work with the voluntary sector and with the university, just around trying to encourage and provide mentorship to some of those young women who actually want to go into education. We do loads of work with the voluntary sector around social prescribing, as other places will do, again trying to provide non-medical solutions, in terms of isolation, etc. So we spend a lot of money with our voluntary sector, really trying to get underneath the health inequalities. The problem is that we have a joint strategic needs assessment, which measures all of the things that are wrong with our population, as Nick already alluded to. And as he said, people get it out every year. And I think I've been in Hull 10 years now, and I haven't seen much movement in the dial. In fact, I've actually seen areas where we've gone backwards. And how is that, and why is that? And I think often places, and particularly local authorities, invest in infrastructure, in buildings, in theatres, but actually in a place like Hull, we don't invest enough sometimes in our people. So we invest in place, but we don't invest enough in people. And that's where we have to have that courageous Cabinet Office offer that is aligned. DHSC needs to work alongside the Cabinet Office, because Hull has seen year-on-year cuts in their social care services. So children's services, children's centres, which were remarkably successful supporting parenting, we've had to close those over the years because Hull's allowances have been reduced. But all that does is have a knock-in impact into something else. So there has to be, in levelling up, there has to be that holistic look. And actually, what are we doing, across our public services, and how do those policies, how do they? So sometimes there's no look around interdependency. One department will have a policy change, they won't actually look at the knock-on impact on other areas. And as somebody said, we get loads of money in the NHS. I'd rather have less money in the NHS and put that money elsewhere. But we will never do that if we just keep looking at 4-hour waits and 18-week treatment. And to me, they are failures in the system. If you need urgent care, you might need it in 1 minute, you might need it in 24 hours. These are arbitrary targets that mean nothing to most of us. And so again, but loads of money goes into meeting those, rather than the prevention agenda that we all need to put money into on a long-term basis. And there's been cuts to public health budgets, as you know, as it's transferred to local authority. How's that? How can we square that really? And again, so I think there are lots of examples. We work with we do loads of work in our city around trying to support people, but I still don't think it's joined up enough, and I don't think we're brave enough, and I don't think it's long term enough.
Nick, tell us a little bit about what you're doing in your area to partner up with local organisations to really fulfil the criteria that you talked about earlier in trying to get people in poor areas to engage with the health service.
So one of the things that we did a long time before Marcus Rashford is that we absolutely recognised that children who were getting free school meals were going hungry during school holidays. And so it was actually the local art gallery, first sighted Colchester, who contacted me and said, can you help? Because we want to open up the art gallery. We've got a restaurant here, which is a lobster restaurant in the middle of Colchester. Never quite worked that out. Not exactly needed. And could we use this to feed kids? And then what can we wrap around those families? So that's now been incredibly successful. It's been running for about 4 years. And we used, in fact, not even as commissioners, we used some of our acute budget to do that. And I think, you know, as Emma said, you know, we got quite heavily criticised for that. But the impact of that in terms of sadly addressing some safeguarding issues, but supporting the women mainly who are bringing their kids to that lunch, giving the children some exercise by involving the local football club, Colchester Town. So First Sight is
Colchester United, I should correct you.
I do apologise. It's a funny shaped ball for me, Ian. I don't really understand it. God, this is going to go out live. I'm going to get murdered by Colchester. There we go. So I think there is something there about that's a really, really good example where we've taken a bit of a risk. Can I just make a point about leadership, if I may? It's interesting. Emma's been in Hull for 10 years. I was perhaps critical of MPs earlier about a short-term agenda. I think one of the challenges that we have in health and indeed in care is around longevity of leadership. The average chief executive, I think, is now 2.5 years. So if you're working in the back of your mind, I've actually been here about 9 years, but if you're working in the back of your mind to your career being based in these aliquots of 3-5 years, then again, are you going to effectively work with partners? Are you going to build a long-term strategy with partnership? And we know that ICSs or whatever they are based on relationships. If you're having to build new relationships every 2 or 3 years, so should we be incentivizing leaders, not just politicians, but leaders to take a longer term view? And how do we incentivize leaders, whether in health or care? And it's obviously a classic criticism of consultants and other leaders. Well, you're only here for 3 years, Nick. Why should we back you? Whereas,
why is that? Why do chief executives not last very long?
We get sacked or promoted, Ian, frankly, to put it crudely. So it's I'm very lucky. I've been here a long time, but the organisation has grown from 250 million to 800 million because we've acquired 3 different organisations. So that's, to be honest, that's what's kept me here. If I was just managing or chief executive of a single site DGH, at some point, I think as leaders we outgrow that. So I'm hoping that the new leadership offer that might be offered through the ICSs or encourage longevity in the ICS leadership. So at least you've got some people around in it for the long term, and maybe looking at the leadership careers, because I suspect somewhere, whether it's conscious or otherwise, we're kind of thinking a 2-3 year agenda rather than the 5, 10, 15, 20 year agenda, which is where we should be. So who are the people who are around the longest? Often the local politicians, but of course, as was mentioned earlier, their agenda is to wait until the next election comes around and make sure they've done nothing too controversial in the previous 3 years.
Is that a fair criticism, Anne?
A fair criticism of whom? I think Nick's point about leaders in the NHS moving on is very valid. It is the trouble. You either outgrow your institution or you're sacked. And these relationships, as you will know, Ian, are really hard to cultivate. And once you've got a chief executive, say, of a local authority, chief executive of a trust, maybe a vice chancellor at a university, principal at an FE college, who could all stick around for 6 years. And, you know, I take Andrew to task. He mentioned universities. Never forget the FE colleges, which are real engines of social mobility. You get those sort of personalities who are in it for 10 years or more, then you can really achieve change. Those relationships are best made when they're casual. You can phone somebody up, text somebody, and all the rest of it. But sadly, that's not how management careers in the NHS have gone. I've been quite interested. I've talked to a lot of NHS trusts recently. Actually, I've been quite surprised how many former nurses are now chief executives, which I think, obviously I'm very biased, but I think that's a very positive thing. you can't really blame politicians. They want to get re-elected because they believe that they're doing good. So they will respond to the electoral cycle and to the people who vote. You can't blame them. It is how it is. But what I think that we can do is, if you disconnect some of the wires between their decisions and the sort of controversial decisions maybe that Nick is making on who to put at the top of his waiting list, that then helps. And I think, that has been an ambition of many politicians, from Bevan and onwards. I mean, he was the first one to comment on it, that he didn't want to hear bedpans clattering in Whitehall. If you can break some of those links, so you free the system up, then it does help politicians. And let's hope that the ICSs do what we would like to see them do.
Let's finish off by talking a little bit about the effect that COVID has had on levelling up and how long it will take to recover. Because going back to the initial point that Nick made, I mean, we all think about waiting lists. That's what the media always obsesses by. Well, how much time have the waiting list gone up over COVID? And obviously, in a lot of areas, they've gone up a huge amount. How long is this, Emma? Let's start with you. Is this going to really affect the levelling up agenda in health, the time it will take to recover from COVID, and effectively the amount of money that's put into the NHS to help it catch up very quickly?
Well, I think it goes back to the fundamentals that we were all talking about, and I think relationships are absolutely everything. So I've acquired 3 other organisations since I've been. That's why I'm still in Hull, but I'm doing East Riding, North Lincolnshire, the ICP, and I'm chair of an acute services review. So I've got quite a full agenda. But
this is called empire building, isn't it, Emma?
But the success. But what I would say is, over the years, people have said, "Well, come and work in Leeds." I've invested years of my life in those relationships with those local authority chief execs, and the chief constable, and the chief fire officer, and the people in education. That those relationships mean everything, because they're so important. Because you can have any governance structure in the world, if you don't have relationships and like-minded leadership and values-based culture, and you're not going to get the outcomes. And that's the problem. We're very good at redesigning the deck chairs in the NHS, but actually, I think this opportunity, regardless of the pandemic, has exposed things that we already knew. It's heightened the inequalities that exist in the patches that we serve. And there's been some great learning around using technology, doing things differently. But again, we've got communities that aren't very literate, when it comes to digital literacy, they aren't very, and again, it's exposed some of those things. So we've got to be mindful that all this learning is great for some people, but not for others. But I think what the ICS does, it gives us an opportunity perhaps to move away from those very top-down political targets to actually things that mean something, that matter to people, which is around health and well-being, jobs, friends, education, good housing, employment. And those things matter so much more. And I think we've got to have a conversation with ICS leaders and with, and with the government and politicians about actually what we're trying to do here. Because we can just have another NHS reorganisation that focuses on 4-hour waits and 18 weeks, but that's not going to improve the health and well-being, nor is it going to level up. So health is just one part of this, of the levelling up agenda. But a lot of roads lead to us when people don't get the lives and the opportunities that they should have had. So I think let's not. There's half of my waking life is spent on elective recovery. But actually, if that's all I focus on as a leader, then I'm going to get it wrong, aren't I? Because I need to be focusing on prevention, skills, education, getting a workforce into the Humber, by working with our UTCs, with our technical colleges, looking at, really trying to industrialise the offer so that we can start to fill healthcare, home care vacancies. Lidl and Aldi are paying more than we're paying our social care staff. We've got the situation is dire. Why is that? We're not levelling up even in terms of paying our staff well. And so, there's some really big questions, I think, to think about as we move into ICSs. I don't want to get caught up in this NHS mantra of waiting list management. I want to get, real in terms of people's lives and the difference that we collectively as system leaders can make to their journey and the opportunities that we can present. Because if I just look at it through a pure health lens, then I'm not doing my job.
Emma, thank you. Nick, let's come to you. The effect of COVID-19 on the levelling up agenda.
So, Emma, it's music to my ears to hear that. However, we went into COVID with 14 people waiting 52 weeks across ESNEF. As of this morning, we've got 3,700. So if I absolutely spent my time where I want to spend it, where I think my career has brought me to, which is about determinants of ill health, which is about the levelling up agenda, which is exactly as you described, employment and young people and unemployment and self-esteem and self-worth and everything else, and yet, you know, I ignore those, and I wouldn't ignore. So I think there is a real challenge about the expectation that's put on health and social care, and I think actually we were starting to get into a really good place about having those conversations, and then COVID came along. You're absolutely right. The biggest risk is that we ignore that. It's got to be both and, but there are only 28 hours in the day, or that's what it feels like. And therefore, how on earth are we as leaders going to manage the two? So part of it is about using the waiting list challenge to address the inequalities. I think there's an opportunity, as I was alluded to earlier, and that hopefully will drive a different conversation about the people we're leaving behind, because we can't leave anybody behind, and COVID's shown us that, hasn't it? But equally, we can't ignore 3,700 people waiting a year for treatment.
Andrew?
I think it's worth thinking about why did more people die in deprived areas than less deprived areas? It's because they had a higher prevalence of heart disease, asthma, diabetes, kidney disease. This is not a comprehensive list, COPD, etc. It's basically it's something great cliche, but prevention is better than cure. It's also cheaper than cure. Unfortunately, the feedback between prevention and the comeback it is long, and I think we do need a bit of bravery and cross-party kind of leadership. That's why I like the levelling out type approach on this, because it does require a bit of commitment. The point is, if those people were had less underlying conditions, whether they were Black, Asian, or poor, or whatever ever social indicator, then they wouldn't have been likely to die in the numbers that they did. You know, I mean, it's pretty, you know, it's crude putting it like that, but that is essentially it. So you can make a difference to this, and you know, we live in we don't know what's coming after COVID. I don't want to be a Jeremiah about this, because God knows, but I think it's been a bit of a wake-up call, isn't it? You know, is that we can't, you know, that we can't afford these inequalities. Never mind never mind the impact on those individuals and communities.
And let me turn to you just to round things up. Do you want to just sort of maybe look at some of the themes that we've discussed today, and maybe give us a little bit of cause for optimism in the future about levelling up on health? Because I think it is one of those subjects where it's quite easy to think negative thoughts, isn't it?
It is, and actually, Ian, I was going to end on an optimistic note. I am a born optimist. I believe everything is possible with commitment, and often, interestingly, for a former politician, with politicians off your back. I think the real optimism I would pull out from this is from the fact that when we went into COVID, I think I felt like a lot of people felt that actually, in order to recover from the damage of COVID and to get things back on their feet in the health service, the rest of the public sector, and in business, everybody would be very inward looking, you know, facing the big waiting lists and all the rest of it. And in fact, precisely the opposite is the case. I have been staggered with the number of people who are taking calls from me to talk about levelling up. I think it is that in your face realization that inequalities bore so heavily on those from most deprived backgrounds that I think has finally made people realize that unless they do something, those inequalities will get worse. So I think there is real cause for optimism. I think that people are taking leadership really seriously, determined, as Nick and Andrew and Emma have displayed, that they are not going to let this continue, that they are going to push away the barriers that sit in front of them, have the conversations that they need to have with all the other agencies, because they can't do it on their own. That realization is like a breath of fresh air. And it is the communities, the people in the places where your organisations sit that actually will be the beneficiaries of this.
I think one thing that I'm going to take from this is what Nick said right at the beginning about the lady that he visited in JWIG, who said, "Oh, you're not going to ask me what I want, are you, anymore?" And I think a lot of, I mean, Anne and I will remember as political candidates doing lots of constituency surveys where you sort of send out to the whole electorate saying, "Oh, what would you like us to do?" And sometimes people just want you to tell them what you're going to do and make a judgment on that. So I've really enjoyed this hour. Thank you so much. Thanks to Anne Milton, Emma Latimer, Nick Hume and Andrew Atfield. There are many other Levelling Up seminars available on the website if you'd like to have a look at those as well. And join us again next time. Goodbye.